Great. Thank you so much for having me here today. It's an honor to be here. It's an honor to be here because I live, unlike most of you, about 2 miles away. And it's very easy to get here. It's an honor to be here because you hear the presentation before and go, oh my word, what's going on in the world? At least that's what I thought. And I've got 3 teenage daughters who are 22, 20, and 16. And I understood their shopping behavior better in the last 20 minutes than I've understood in a long time. So, it is fantastic to be here. As I've been introduced, I'm going to take you on a brief tour of what's going on in primary care. And I'm going to talk to you from different perspectives. And one of the fun things I'm actually going to try and do is make sure that by the end of it, you understand the NHS. Now, you'll know that's pretty hard. And lots of things are hard. So I do have multiple roles. I'm a local GP. I'm a commissioner of healthcare for a population of about 500,000, fairly close to here. I'm involved in setting up a new medical school in Birmingham. And then I work a couple of days for NHS England trying to make primary care better. For those of you who don't know, primary care hasn't changed very much in many ways, but it has changed. And I'm hoping that there's some similarities between what you hear me say in your industry that you can beg, borrow, or steal, or some things that you'll see that have changed that you'll go, the comparisons are interesting. Now, one of the things that usually happens at this phase is someone speaks to me and says, how on earth have you got into this mess? And they imply the job that I'm doing, not the healthcare system at all, and not primary care. But that's because I'm interested in doing new things. So fairly recently, I've started learning about new things, and I'm going to show you one of my latest things. Is that okay? Okay, so I'm interested in magic. And so we're going to start by, I'm going to show you some cards, okay? And when you see them, I want you to choose one of the cards. There are 5 cards, I don't mind which one you choose, but you're going to choose one of the cards. I'll leave it up for a second, then I'm going to take the cards away. Is that fair? So I think there are the cards. Just choose one of them. You all got one? Okay. So now, either because I'm a magician or because I've done my homework properly, I'm going to make your card disappear. Has your card disappeared? So I want you to put your hand up if I made your card disappear. That's amazing, isn't it? How cool is that? So now for me, this feeling you've got now, this feeling, okay, is what it's like when I say to you, your job is to try and work with the NHS. Is that right? How? It's like, I know something's just happened. I don't quite know what's happened. It's all changed. Things change. It's got a bit different. But somehow I've got to work out how to work with this thing. And it feels a bit like magic. Now, for those of you that are really, really astute, will have worked out that actually the first set of cards is the top one, the bottom set of cards is the bottom one, and none of the cards are the same. So I made all of your cards disappear, okay? And that's how you do magic for this many people. But of course, this is really what the NHS is like, okay? And of course, it's a pretty complicated diagram. We've got lots of stuff down below, structures and things, and we've got lots of things above, providers, and it forms this beautiful tree, which is kind of a bit of a mystery. Now, amongst that, we have this new thing emerging, which we're calling STPs. They stand, STPs, happy with that as a term? System transformation plans, we'll get there, I promise you we're going to do. And if you look at the STP, it's that little green shoot in the bottom right-hand corner. And what STPs are doing is saying, do you know, the thing that's really interesting is when the NHS was started, it basically worked on a principle that actually STPs are trying to work on now, which is to say, if you want to put all that stuff in an area together locally, what would that look like? And so I wouldn't concentrate on this beautiful blue tree thing that we've created. I'd concentrate more on this because STPs, Sustainability and Transformation Partners, are what's going on locally in regions. And there are 44 of these across England. And they're supposed to be the merging of primary care councils, CCGs, ambulance trusts, mental health trusts, community trusts, and hospital trusts. I assume a level of health literacy because you're involved in health. So if I use a bunch of lingo that doesn't make any sense, someone stick your hand up and say, what's one of those? And I'll try and explain them. So the idea is that across 44 areas, and Birmingham's one, West Birmingham, the Black Country is another, they're looking at transformation, assuming financial balance, trying to improve health and social care locally, thinking about system resilience. And my job in many ways is to say, so what does that look like for primary care? So the health needs of our population are substantially changing. In the same way that we've heard ITs charging at a fantastic rate in a way that we either like or don't like, but that's quite an interesting thing about how we access healthcare. There are massive changes going on in our population. The aging population is making a substantial difference. You're currently sitting in Birmingham. I don't know if you heard that when the Commonwealth Games was handed over to Birmingham, this is the centre of the Commonwealth. That was decided on that moment when we received a thing to say the Commonwealth Games here are coming in 2022. It was assured Birmingham that it's the centre of the Commonwealth, so welcome. The other thing about Birmingham is it's the youngest city in Europe. Okay, all the healthcare planning in Europe didn't get what was going to happen, and that's because education was one of the few things that wasn't hampered so much by some of the financial shenanigans, that's a technical term that we've had to put up with. Some of that has meant that industries around education have changed, so we've had a 10% increase in students in Birmingham in the last 10 years. And one of the really, really interesting things is that there are more smartphones bought in Birmingham than most other places, but they're not bought, they're bought in the over 55 market. And so we've got a very digitally connected city, and so some of the experiments we do locally are saying, well, we've got an aging population, but what do you do? How do you access healthcare? Some of you have all heard of something called GP at hand. You can get a little thing on your smartphone that talks about accessing primary care. The other thing that's happening, of course, is that the NHS is the most amazing sickness service. But the question is, what do you do when you're trying to treat chronic conditions, when you're trying to take the role from being individual episodes of illness to help managing long-term conditions? And then the other thing that's quite interesting is how innovation changes health and how we move from being something which you accessed healthcare in olden times more of our hospital, but you can do more and more in the community, and the question is, how do you pick that up? So, 20 years ago, I started as a GP in a bit of inner city Birmingham that's about 4 miles from here. And I would say there was 3 types of patients that I saw. And about 80% of the people that I saw, you can sort of stylize in somebody that I call Ian. And Ian's somebody, he could be a sick child, but it's somebody who's sick on the day, somebody who needs to see a doctor there and then. And I guess it's like most of you, is when you ring the GP, it's kind of nice if you know who the GP is, but you just want someone that's good at what they do. Yeah? Unless you've got a chronic disease. And of course, about 18% of people have one type of chronic disease. And so my sort of stereotypical image of this would be someone we can call Christine. She's got diabetes, and she accesses care in a different way as well. And then, of course, 2% of people have got a complex mix of conditions, often with dementia or something else like that, where they really need to know there's a team of people around them. And 20 years ago, we were using a system where we had a big queue outside our door. 10 years ago, we had changed because we'd grown from having about 5,000 patients to about 12,000 patients. And the interesting thing is I've talked to you about all the changes in healthcare, but we hadn't changed any of the model of primary care. And so we were using a pretty outdated model. We got twice as many patients. And what I've called the hand-me-down model of healthcare, which I received from my father and my grandfather, who were both doctors, was no longer sustainable, and things had to change. So for someone like Ian, we had to do something where they had to work out, if one surgery is busy, can you produce a contact hub so that people can access care in different ways? For Christine, she wants care in a very different way, because actually, the people that are best at managing chronic diseases are not doctors. They're the nursing staff. They're the people around the primary healthcare team. They're the people that are much better at managing it than I was, and I still am. So how do we empower those? How do we train those to happen? And of course, someone like Stephen, Stephen's still got a disease which we can't cure. There isn't a cure for dementia, but it is now becoming the commonest cause of death in ladies in this country. And so therefore, what are we going to do? Well, they need a focused package of care around them. They need multidisciplinary teams. They need some way that the carers of Stephen are being looked after as well. So moving towards a healthcare system where complex conditions become our challenge to deal with, I think is the journey of primary care. And that's some of the journey we've been going on as a provider. So, my practice that I'm involved in now, we don't have a waiting list. Sorry, we don't have a line of people sitting outside. There's no queue on a Monday morning, which there used to be. You could say there's a queue on the phone, and I would say that's true, but at least people are accessing care in a new way. We've got, in our partnership, 325,000 patients. We're using technology in place to change some of those things, and we're producing faster treatment for patients. So what is going on in primary care? Well, there's a traditional practice model, which I've used random green blobs, which I'm sure you can relate to. I think some of your industry is the same. We're seeing what we're calling federations, which is loose groupings of primary care providers. And then we're seeing full mergers into what's called super partnerships. And so the practice that I was involved in was one of the first super partnerships in this country. And then on top of that, we've also got various mixes of things. We've got federations plus super partnerships. We've got super federations. Lots and lots of terms of how primary care is changing and scaling. So the practice that I'm mostly involved with on the Monday that I work as a GP, I've told you we've got 7 regions now: Sandwell, Birmingham, Walsall, Wokingham, Hull, and other bits of the country. So it's a single partnership and a single NHS ethos-driven unit. And I now have 120 partners when I used to have 5. It's quite common for me to come to somewhere like this and someone to say, I'm one of your partners. The other thing that sometimes happens when I speak in Birmingham is somebody puts their hand up and says other things that they know about me, because I've been born and brought up in Birmingham all my life. The worst thing that ever happened to me was I was sitting in an audience like this and I recognized somebody who would given me my first job in leadership. And I tried to honor that person and be nice to that person. And a lady stood at the back and said, are you Carol Starkey's son? And I was like, yeah. And she went, well, 21st of December 1969, I brought you into this world. I was like, oh my word, this is getting surreal. So if you know me in any other way, please forgive me. So this is how we're doing primary care, and this is what primary care is doing locally for us. And we're seeing joint working between the whole of the primary care unit locally, not just general practice. So what's different? Well, I think you can do 3 things that are different. You can have some form of contact center on the left-hand side where you can use lots of things that we see: website optimization, patient apps, rerouted NHS 111 calls into primary care. At the practice level, the patients still see a GP in their local practice. We're not, in some areas we are putting lots of GPs together, but mostly we're leaving the primary care units where they are. And from that, we can have standardized clinical templates. We can do new things. I talked about MDTs. We can have enhanced services there. We now provide the largest community dermatology clinic in Europe. Most skin things you don't need to go to hospital for, but the question is, can you work well with your secondary care provider to do that community shift? And of course, you get some of the scale in the back office around HR, governance, IT. And so lots of primary care is doing this in lots of different ways. And whilst the system has changed, it's still not changed enough for the whole of England yet to meet the patient's needs. About 4 years ago, NHS England started something called the Vanguard Program, which some of you may have heard of. And here's a few examples of Vanguards across the whole of England where they're using the totality of the primary care team to show that integrating services provides improved service for patients. Everyone talks about, not everyone, in my world, Tower Hamlets is one of the beacons of what's going on in primary care. And you can see their use of care coordinators has made some real changes. We could take you up to Wakefield in Yorkshire, where they have integrated teams across organisational boundaries to make some changes and actually show some of the big metrics in the NHS that we look at and see those change. And then somewhere like Morecambe Bay, where they've been working, tying up better local out-of-hours hospital providers. So is that really making a difference is a good question. Well, some of the data that we're looking at says that where some of the there are 4 different types of vanguards, where those vanguards have been moving forward, we can see a slower growth in emergency admissions. So there's a general feeling that where you empower local communities and local providers to do new things, then you get some of the changes that we're trying to shift in primary care. And the clicker's died. No. So of the 50 vanguards, and now moving to more a national perspective, trying to think about what we can do with those vanguards. You then end up saying, well, can you actually empower 44 areas of England in STPs? We've talked about those already. And can we see a cultural shift towards system leadership? Can we see the right environment for incentives to work? Can we see sustainable and autonomous systems that work in their areas doing what's right for their local population? There's an expectation those systems will mature, and in a minute I'll show you one of the timelines of which the NHS is expecting those systems to mature down. So the role I have is to say, wave one of those 44, okay, we're going to call them ICSs. So now we've got another three-letter acronym. We started off with 44 STPs, and we're going to have ICSs. Is that all right? Integrated Care Systems. And they're in waves. We've got through wave one. Wave 2, 3, and 4 haven't been announced yet. So wave one, and you can see the blobs of where they are. So I guess some of you will come from bits of that bit of England. And so the question then is, putting all the knowledge, all the thought process into those areas, for 1819, can we have a single system operating plan? So not a commissioner-provider operating plan, not one hospital with a plan, not with a CCG with a plan, not the community with a plan. Can we have a single operating plan and narrative that aligns commissioners and providers? And where we can adopt a system-based approach for provider and commissioner sustainability funds, we can actually make the system work better. It's often true in the NHS that there are several things that are diametrically opposed that are both true at the same time. The NHS is an amazing thing, but it has the ability to be more efficient. Of course, it can be more efficient, but it also needs more cash to make it work. And those two things aren't diametrically opposed, although they do sound it. So in these units, in these ICS areas, what can we make them financially sustainable? So you end up with all 44 areas of England going on a journey from STP, shadow ICS, full ICS, and to something called a mature ICS, where maturity is shown by partnership working, embedding in all the levels of the system, and public engage with healthcare. The emergent findings of the Wave 1 ICSs says that there are some really important things that help to make sure that integrated care works, and there are important building blocks. Now, this is where it gets interesting, because some people are saying it should be big, and some people are saying it should be small. And of course, you need to do both. I used to have a Toyota Yaris, and the advert for the Toyota Yaris was that it was a big, small car. It wasn't, it was a small car. Okay, I've got a bigger car now. But it was advertised as being a big, small car. And the thing is that's interesting, one of the amazing things about the NHS is that 90% of all activity happens in primary care. And it happens well when there's a team in the primary care doing something which knows its population. So the question is, how can you do the big stuff and keep that as well? So that when, yes, you can get the direct input from a patient who needs to see you on the day, but you also have some continuity of care. So can we have a core team of 3,000 to 4,000 patients? Can we have primary care networks, which is the kind of the new thing in what we're doing in England, where we actually have network bits of primary care in units of 30,000 to 50,000 patients, thinking more particularly about urgent care, locality-tailored services, sharing MDTs. We talked about MDTs are the things that for our high-user patients that need where we can work together to make those teams work for high-user patients. But you need to be in a bigger unit than 3,000 to 4,000. And then do we need to think about a much bigger unit on top of that? And it's all about 10 times bigger. You need something that's 10 times bigger. So whilst I've talked about the ICS footprint, which is the bigger one on the outside, you can see why you need smaller units in that as well to make sure that healthcare is being delivered well. So coming back to primary care, which is the greeny coloured slide on the far right-hand side, what we're trying to do in networks is link primary care in units together, so enhanced access, resilience, and they can share workforce together to provide proactive services. So one of the ICSs that we could zoom up to would be South Yorkshire and Bassetlaw, and this is what they're doing. South Yorkshire and Bassetlaw is an interesting place because it's not really a place. South Yorkshire is one, Bassettlaw's a place, and the towns in between are. So how are they doing that? Well, they're in one STP. They've got 3.9 billion health and care budget with 1.5 million people. And so geographically they look like that, but organisationally they're beginning to look like something on the right-hand side, with subunits around the outside and a core central planning unit in the middle. Let me touch that. And when you get the GPs together in the room around these units, and when you say to the primary care units around the ICSs and say, what would really, really help? Well, what they come up with is the things that I'll show you, which is, can we get a new model for primary care for the future? Can there be other ways to manage GP workload? Can there be teams that are resilient to fluctuations in demand? Can we have improved population health, where the population models that I've talked about, where you change things to meet the demands of patients in new ways, can we do that? And can we use the system resources that we already have in a better way? And so we've done some work basically saying we think there are 5 things that need to really happen in integrated care. One is it needs to be at the right scale. The second is we need to have integrated working across the whole of primary care, including community services, social care. And we need to understand our population needs and target care. We need to manage resources and reduce variation, and then make sure that primary care has a voice at all levels, because as a provider, primary care hasn't had a voice previously. That produces integrated care systems, and where you can join up care in the best way possible, that's where you get care that's focused on patients rather than organisations. This is a busy and complex slide, and it's here not to make you go to sleep at this time in the day. It's here to say that actually of the Wave 1 ICSs, we've produced this matrix for them. And again, it's a tool that, it's a planning idea, which basically says, if you take the 5 themes that we've talked about and then say, how do we get integration of primary care together? And there are 4 steps that we've come up with our primary care teams across the Wave 1 ICSs. So starting on the left-hand side, you need to have a plan. You need to engage your GPs. You need to have time for primary care in particular, because like a lot of you in this room, we're all working pretty hard and flat out, so you have to make space to do that. And then you have to have some transformation resource to do that. All the way over to something on the right-hand side, which would be a fully networked business model of primary care in units of 30, 50,000, 7-day working well, taking a collective responsibility for funding, and then primary care network having full decision-making member of the integrated care system above. In Frimley, which is another one of the Wave 1 ICSs, we're seeing some quite substantial changes as a consequence of the things that they're doing. We're seeing that referrals are going down, since, as you can tell on the left block, 17-18, and their emergency admissions have gone down as well in ways that are quite remarkable. Now, the NHS is a complex system. Is it all due to what we're doing? Almost certainly not. But is this part of helping it make it work? We think so. This is BLMK, which stands another unhelpful acronym. Bedford, Luton, Milton Keynes, which is another one of the Wave 1 ICSs. I had to think which one it was. And so this is them basically saying, where are we on that map that I've just shown you, and what does that look like, and what do we need to do this year to move their primary care units towards the right rather than the other way. And of course, I've never met a GP that got up in the morning and thought, I really want to do a bad job. I've never met a clinician that thought, I really, really want to do a bad job. But I've met lots of clinicians that went, I want to do a good job, but it's really hard because the system's complex. And I've never met a GP or a clinician that got up in the morning and said, I know, if you hit me over the head really hard, I'll behave better tomorrow. Okay? But actually, if you start, even rather than telling doctors what they're doing and start to show doctors what they're doing, then actually you remove unwarranted variation, which is actually what managing a healthcare system's about. And so we're beginning to show there's lots of emphasis put on technology dashboards, and this is one of many that I could have shown you, which says for all the practices, which they don't matter, can you rag rate them? Can you say, oh, how are they doing in their metrics? And then say, you're doing something really interesting in your practice that we're not doing because you're green and we're red. Why? And so where you empower that in local teams, you see system changes that are really quite interesting. I think I've got one more slide. There are two games that I think are quite interesting. Jenga's a game where the word Jenga is a Swahili word, which means to build. And Lego comes from a country, and the root word of the word Lego is also to build. One of these games is really stupid. A game where you pull a block out and wait for the tower not to fall down means there's no winner. There's just a loser. But on the other hand, where you get blocks of Lego and where you take them and you go, let's create something new with them, rather than pulling them out and throw them away, people just create the most amazing things. The number of Death Stars and Star Wars creatures that I've seen built, and just amazing what people build with Lego. And actually, I think this is what we're trying to do with the NHS. We're trying not to play Jenga. We're not trying to take bricks out and throw it away and go, well, the tower's still standing, so it's all right. I think what we're trying to do is play Lego. I think Jenga's a rubbish game, and it should be banned. Thank you.